Okay, we'll get started. It's actually a real honor to be able to introduce Dr. Dunnington. He's the professor and chair of the Department of Surgery at the University of Indiana, J. Grosfeld professor. He's been a surgical educator his entire life. He has won countless educational awards throughout his career at every institution that he's been at. He's been a program director. He is a past president of the Association for Surgical Education. He has received the Outstanding Educator Award from that organization in 1999. His clinical interest is in oncology and breast cancer. He has been the PI or co-investigator in over $5 million worth of grants. He's published over 125 individual papers. He's been visiting professor at over half the medical schools in this country, which is a really remarkable thing. His first visit to West Virginia, so that's great for us. And from a personal context, he was one of the 5 founding directors of the American College of Surgeons as Educators course, which started in 1993 and is still going strong all these years later. And that's actually where I met him 23 years ago. He, as I said, he is a consummate communicator and educator, has always been a leader and a visionary in new methodologies for assessment and training. And it's a pleasure to have you, Gary, and I really look forward to what you have to say. So thanks for coming.
Thanks very much. See. Thanks very much, David. And it is good to be at this university. My first time at West Virginia, and to see some old friends. Surprised to see David after all of these years. I believe that you were in that very first Surgeons as Educators course. I have nothing to disclose. I bring you greetings from our institution, which has, for me, been a challenge, moving from a smaller medical school of Southern Illinois University for 15 years to a very large institution. We have about 10 residents a year in our general surgery training program, and our residents and faculty rotate through these 7 hospitals across the Indianapolis area, 5 of them on the main campus and then others as outliers. So it is a challenge developing uniformity and educational aspects across this campus. I'm talking this morning about how we evaluate the performance of learners, both medical students and residents. And I want to begin with a little reality. This is based on good evidence. 20 to 25% of residents have performance problems identified during training. Most see that and their immediate assumption is, well, not our program. We can't be that high. So when my PhD educator first brought this information to me, I said, well, not us. SIU, that's not the problem. Let's do a 30-year search of our resident history and see what our figure is. And we did just that study, and it was 23%. So it's consistent. Medicine, family medicine, surgery, fairly typical. Most problems are identified early, but then there's real delays in addressing the problems. We have very poor evaluation strategies, so we don't do a good job with diagnosis, and our remediation is sort of a penicillin for everything. I won't ask, but how many residents have been told, you just need to read more. That would solve the problem. And seldom is that the only issue at stake with resident issues. Most residents then complete training with the same problems we identified early on that were never significantly addressed. Several years ago, we tried to, from our perspective, look at the reasons for these problems in resident evaluation, and we really believe they're in this order. And it's a little different than what others might suggest. We think the problem is we don't sample enough performance, so we don't have enough ratings or raters. That is by far and away the biggest problem. There are some inaccuracies due to over-reliance on memory. The best example, end of rotation evaluation, fraught with all kinds of problems, where at the end of perhaps 2 or 3 months, we're trying to recall all of those incidents with residents and reflect them in an evaluation. As a colleague of mine once said, it would be very similar to doing 2 to 3 months of clinic visits and then decide I'm going to do the dictation on those patients over the last 2 to 3 months. The record would clearly be inaccurate. The others are probably less of an issue, but often considered high on other lists. This was some frightening information presented at American Surgical just a few years ago. Actually, the key author was from Indiana University. This is Council of Fellowship Directors. So these are fellowship directors receiving residents after 5 years of general surgery training. 43% felt that incoming fellows were unable to independently perform 30 minutes of a major procedure, and 30% felt that they couldn't completely do independently something so basic as a laparoscopic cholecystectomy. This caused lengthy discussion among educators when this was first reported. Along about the same time, Dick Bell, then the chair at Northwestern and president of Central Surgical, gave his presidential address on why Johnny cannot operate. And I think what I would suggest is why Johnny and Joanna can't operate is really a couple of things. It's either inadequate experience in residency training, which we were touching on just a few moments ago, but I'm not sure it's so much a volume issue as an autonomy issue, and I'll come back to that. And then a real critical problem is the absence of formal assessment of operative skills. I've been to some of the most beautiful simulation centers, surgical skills laboratories, and they show me an incredible curriculum. And when I ask, show me your assessment of performance to prove they've learned those skills before going to the operating room, the answer is, well, we don't really have that much time available by faculty. And so I want to say that, as Lord Kelvin said years ago, if you cannot measure it, you cannot improve it. And I think that's at the heart of the problems we're seeing currently. So I want to mention how we look at measuring and improving performance in some of these areas. End of rotation evaluation, we've tried to make it better. Surgical skills performance, team-based performance in the operating room, measuring autonomy, and just very briefly about clinical assessment and management skills. In an effort to improve what we think is this really poor measurement of end-of-rotation evaluations, my PhD educator one morning came to me and said, I was reading consumer reports over the weekend, and I think I learned something about how we could change resident evaluation. He said when consumers are asked to evaluate an automobile, they're given several systems and asked, do you have any problems in any of these systems? And that's how they do consumer reports. So he said to me, I think that would give us a more precise evaluation of residents if we said, are there any serious performance problems in these areas, rather than just a global rating on 1 to 5. So what we call our end-of-rotation evaluation, or the clinical performance and behavior performance form, we rate clinical performance, professional behavior, and performance relative to residents at the same level. That's a short form. It took him almost 3 years to convince me it doesn't matter how many items you have on your rating form. Faculty only see in 2 perspectives: professional behavior and clinical performance. When he finally convinced me of that, we shortened the form dramatically, and this is what it was. And we have previous publication on the excellent psychometric properties of this kind of form. But now we've added something called serious performance problems. And now we've looked at that carefully. We reported our works just a few days ago at Central Surgical in Montreal. We've now used this in over 4,000 ratings, and this clearly shows us being able to provide much more critical precision. Now we know what we need to remediate, a specific problem, much like consumer reports identifies problems in your automobile. Let's talk about the Surgical Skills Laboratory, and I haven't seen the facilities here, but it's an effort I've been involved with now since the early 90s, when I first became convinced this was the future of surgical training. It wasn't a new idea. Bob Barnes at the University of Arkansas talked about it back in the 50s, and then it completely disappeared, and in the early 90s, at the time I was at the University of Southern California, as well as the Toronto group, began to resurrect this concept of a surgical skills laboratory. And it was based on training of professionals in other areas. Let's look at the training of a musician. So if you are a talented young student and you win an award to go to Juilliard School of Music, you don't arrive in the first week and say, I was wondering when I might be scheduled for a performance at Carnegie. Instead, they would say, not even a possibility. In fact, you're going to spend months of your life in this dingy little practice room, and maybe sometime, years down the road, you'll accomplish what you need in the practice arena, and then you can move to the performance arena. And yet our residents often arrive on July 1 and wonder, when do I go to the operating room? Surely in that first week, since that's why I came here, is to be a surgeon. And so the concept of skills laboratory is based on this underlying principle of deliberate practice. always espoused by Erickson, who's written a new book now called Peak. But it's a well-defined task, just the right difficulty level, great feedback, and opportunities to repeat and correct errors. And early on, I believed that the operating room met these criteria seldom. Maybe for senior residents, seldom for junior residents. And thus the idea of a skills laboratory where we can meet these criteria, particularly for interns, second-year residents, every single laboratory. And so as we say in our program over and over again, practice arena before performance arena. The rationale is sound. It avoids exposing patients to the sharpest slope of the surgical skills learning curve. I would not want to go back to the way I was trained when on the first day you arrived in the OR and learned all of these basic skills on a patient. Someone has said the best place to learn clinical skills is as far away from a patient as you can get. I'm not quite that dogmatic, but I really believe we have to avoid putting interns in the operating room before they're ready to be there. Clearly enhances the quality of OR teaching. I'm able to begin at a much higher level than if I'm teaching an intern how to tie a knot. Potential to significantly decrease the number of operative cases. So when people say to me, how are you going to train a surgeon in only 5 years with all of the advancing technology? The answer is train them smarter, train them more efficiently in a skills laboratory where ultimately it'll take fewer cases to reach competency levels. And Ara Darzi at the Imperial College in London has said that hour for hour is probably more efficient to train in a skills laboratory than an operating room. And this data continues to accumulate. Well, now I've been involved in skills laboratories now for over 2 decades. I think we've learned a few lessons. It's clearly of most benefit for junior residents. It's not the place a chief resident ought to be by any means. Has to be a mandatory part of the curriculum. In the first 10 years or so, people created laboratories and made them volunteer. So if you have free time, maybe on a Saturday if you don't have anything else going on and you want to drop by the skills lab, doesn't work. Has to be mandatory, and I think for residents and faculty, that's a culture that takes a while to adapt. Leadership clearly has to be involved. When I arrived at Indiana University, there was clearly the attitude that if there was nothing any more exciting going on, then you go to the skills laboratory. But you certainly don't leave a case in the OR. And so we had to change that culture and call the OR a few times and ask attendings to send residents to the skills lab because this was mandatory. And we've had to do similarly for faculty. And so we have to make sure they're there. Multiple training platforms are critical. You can't just assume you're going to do it all with virtual reality. It requires multiple platforms. We learned after a few years that eventually faculty will burn out. So we've adapted the concept of surgical skills coaches. At SIU, we had 2 people that we brought from the operating room as first assistants, trained them through hours and hours and hours of training, and they were very able to teach some of the basic skills of suturing and knot tying, and now we're looking to see if they may also be able to evaluate that kind of performance. And the more we learned, we realized we were starting too late. We need to really start simulation training way back in medical school, and so our clerkship skills curriculum now is dramatically involved with simulation. These are just a few of the cases that our medical students experience on the clerkship. Beginning this next clerkship year in June, we're doubling the amount of simulation because the more we do, the more they want. Give us fewer lectures. Give us more of these, where they're at the bedside really solving clinical problems. We have a surgery readiness elective, which is finishing up actually this week, and I understand you have one here. This is in our 4th-year medical students who are headed towards surgical careers. This would be any surgical specialty, orthopedics, ENT, urology, any of those. Faculty case sessions, we have a whole series of cadaver dissections. If you're going to be an ENT surgeon, you spend extensive time dissecting the head and neck. If you're going to be a urologist, you do a tremendous amount in the pelvis. We have a whole series of mock pages by our nurse educator, giving them simulated situations from the ward, asking them to solve the problem, and then giving them feedback. These calls go on all afternoon and into the evening hours. All senior students would prefer not to be interrupted. It is a senior elective, but it works very well. And then survival skills and intensive skills laboratory sessions. We think these 4th-year students will begin their residency in July well ahead of the curve on basic laparoscopic skills. In fact, already prepared to pass FLS. Several years ago, I had the wonderful opportunity with a surgeon in Canada to lead a group of surgeons to develop the ACS APDS surgical skills curriculum because we were frustrated that everybody was developing their own. And it was very time-consuming. And And so the idea was to create one curriculum available online to programs throughout the world, actually. It was in 3 phases. I don't know how much of this is used here. The first is for any surgical trainee. The second is for general surgeons. And then the third is really, again, not specific to general surgery. Here's all the modules in phase 1 that we do. We do it in this kind of arrangement. It's called boot camp for PGY1 residents in plastics, urology, vascular, and general surgery, a group of about 30 interns. It's 12 consecutive weeks beginning the first week of August. Give them a chance to get oriented and then put them into this boot camp. Weekly 2-hour sessions, all faculty directed, and they have to pass 9 of 11 what we call VOPs, verification of proficiency modules, before they graduate from boot camp, and I'll come back to that. We do a significant amount of virtual reality training. It's part of this multiple platforms, but there's just a lot of things that are trained on much simpler, less costly modalities than expensive virtual reality. But these are the things where I think it probably is the best choice. Basic and advanced suturing. There isn't a good model for laparoscopic appendectomy. We have not yet found a satisfactory model for lap ventral hernias. So we use it for these things, but often there are other models that are more helpful. I skipped some things here. This is phase 2 at Indiana University, which is largely cadaver-based. So we have a lot of cadaver dissections. And so any of these that are held, the faculty specialty in that area would be required to be present. So if the topic today is a right laparoscopic colectomy, then we would expect at least 3 of our colorectal surgeons to be present for that session. And you can see the levels of residents as well. We've now introduced team-based training, which is probably the most difficult of all 3 of these phases. I think it's absolutely critical. It's very popular nowadays to do interprofessional training. This is the way you do it in surgery. So in these sessions, you can have anesthesia and nursing and pharmacy and all of these groups working together, whether it's in the operating room or in the post-operative recovery room. Here's one of our first sessions, Managing Intraoperative Crisis. Peter Hammer, who's in the center here, I recruited from the University of Southern California, which did all the simulation as all Navy personnel went overseas. As soon as they were set to be deployed to Afghanistan, Iraq, Peter Hammer did all of their simulation training, so he was a wonderful assistant for us in these. This is a laparoscopic case where the trocar is immediately inserted into the aorta, and things go downhill very rapidly. And so there's anesthesia resident, nursing students, and our 3rd-year residents, and they are then asked to lead the team through this crisis. If there's any sense of whether it's realistic or not enough, just notice the sweat accumulating on the brow of their cap. And then after the experience, they then go into a separate room, and Dr. Hammer does the debriefing, which is the most valuable part of these team-based training scenarios. Here are the team-based skills we incorporate in all of these scenarios. And these were all developed. They're online, the 10 modules. So these are the things we're trying to teach. I'm not sure we can teach these any other way. You can't give a lecture on how to manage this kind of crisis. You have to put them in the operating room in this simulated environment. Here are the modules. And again, you can see they're not really specific to the operating room, and in some ways they're not even specific to surgery, but they really teach those skills in all of these 10 different scenarios, everything even to a retained sponge on post-op chest x-ray. It'd be nice to know the steps of how you manage that potentially legal crisis as a resident rather than your first time when it happens as an attending. Hopefully it never does. But recent survey by Korndorfer looked at how widely adapted is this curriculum. And as the group putting it together, we were clearly disappointed. Most use phase 1, fewer use phase 2 and 3. So this is now a couple, 3 years old. What was most disappointing is while this was nationally circulated, 1 in 5 program directors said, what curriculum? So clearly we have some work to do on disseminating this. A group at Duke decided, well, just how costly is this for programs that are saying it's just too much, we can't do this at our program? This was a pretty average size program, 35 modules for 35 residents across 5 years. So this would be a program with maybe 6, 7 residents a year. You can see the average operational cost, but it turns out quite consistently to be about $3,000 a resident. So if you want to know what it would cost here for your 3 per year, that's a way to estimate. And actually we looked at that cost in our own program, and it was very similar. Now, obviously more if you use a lot of VR, but I think there are ways to do it for about $3,000 a resident over their 5-year curriculum. Simulation at Indiana University, we've built a new $1 million, 1,600 square feet surgical skills laboratory. We did not have one as of 3 years ago. We have a center for surgical simulation, which is where we do all of our live animal surgery. And then we have an absolutely beautiful simulation center, which is our team-based training center. So this is our new surgical skills laboratory, and it's built right-sized for our 30 trainees for surgical boot camp. It's also a wonderful facility for CME events, national courses, collaboration with industry, which is really an important funding device for us to keep this skills laboratory going. We think our equipment here, including the lighting, is probably better than our operating room, which is very nice, equipped with overhead cameras so that we can film particularly the verification of proficiencies. This is our 30,000 square foot simulation center where we have inpatient areas, outpatient areas. The simulated operating room there does not look any different than a real operating room where we do those simulations for team-based training. This is our live animal laboratory where we do ATOM and ASSET, the two critical courses for training in trauma. And so we bring all of our residents across the campus together at the third year for ATOM training, which is done in a live animal, so one attending with one resident. While the resident's in the hall, an injury is inflicted on this animal. The resident comes in and makes the diagnosis, and with the attending as first assistant, solves the problem. I'm not sure whether ATOM is offered here, but a profoundly valuable course for residents. This would be in the live animal facility. Let's talk about evaluation of performance, because we've said a lot of folks have these kinds of things as part of their curriculum, but they don't take that critical last step in assessment and evaluating performance, and we think that may be the most important of all. When we first began years ago at SIU, we did this with what's called OSATs, developed by Richard Resnick at the University of Toronto, Objective Assessment of Technical Skills. So once every 6 months or so, we would bring our faculty down to the skills lab, and residents would rotate through 20-minute stations. Maybe they would do a central line, maybe a lap chole on an explant liver and gallbladder, or they would do a skin excision on a pig's foot, and the faculty would evaluate that performance. So it's highly valid and reliable. When I suggested this is what we ought to use for our national curriculum, I was immediately vetoed. And the faculty response from these institutions all across North America said, that will never happen at our place. We'll never get faculty to come twice a year for a half day and evaluate performance. You have to come up with something that's more faculty friendly. And so our research team went back and developed this, the verification of proficiency modules. If we had known the really popular term coming up in a few years, we would have named them Entrustable Professional Activities, because that's really what they are at this point. So all of these things we think are so absolutely critical, we believe they ought to be measured before performed in a real live patient. And so before you graduate from boot camp, all but two of these, which are the arterial and bowel anastomosis, which you don't need for another couple years, you have to pass all of these before you move on. So this is the way it works. First, there is a video, and these are all online on this national curriculum. There's a video of someone performing the perfect vascular anastomosis. So here's the model. Then you have the skills laboratory with the vascular surgeons. Then you follow that with lots of practice. Skills coaches are there to help you along. When you think you're ready to pass, you go into the camera and you're videotaped. We have a video capture system that sends that to faculty desktop where in their own time or at home in the evening after the kids are in bed, they can evaluate that performance. And they ultimately must say, pass, this resident can come to my OR and do an access graft, or fail, needs more practice before they're ready to come to the operating room. If the resident fails, they go back to the skills lab for more practice and retesting. We're doing a different system now, but this was what our system looked like on the laptop in our previous iteration. So it's a blinded video because we're only seeing the hands, so I don't know what intern it is. It's just intern number 1208. But importantly, I can give all kinds of rich feedback along the way, which if they fail, gives them guidance with their coach as to how they need to improve their performance. As all of you know, and I understand this is being done in this program now, residents have to pass fundamentals of endoscopic surgery, and this is an important part. And again, I would prefer someone doing my colonoscopy have passed FES, rather than as I hear them mumbling, how does this scope work and how do these dials work? I'd rather them have FES certification before they do something on me or a family member. Let's move to the operating room, because this was really one of the things that drove this from the beginning, is my overwhelming frustration that every May the chief residents would plop on my desk as program director all the cases they had done in 5 years. And if the numbers were adequate, I signed my name, which meant they're competent. And I always had a sense of, how do I know? Just because they've done a number of these cases, does that mean they're competent? Because we've never evaluated, except for that ineffective end-of-rotation evaluation, which has one item on operative skills. And so we began to really think seriously about how we evaluate in the operating room. Well, because if I don't cover this point, someone will ask it. 80% of the times when I've given this talk, someone raises their hands and says, so could we decide who's going to be a really great surgical resident when we interview them as medical students? That's so tempting. Well, just so you know, the answer is no. It's been tried now for over 25 years. The first report I heard was actually about 25 years ago by Art Schoenemann and Jack Pickelman. This was a very recent, this month, the best I've seen, a comprehensive meta-analysis that looked at 52 studies, 23 characteristics, all of these kinds of tests that might predict this medical student is going to be a great surgeon and a competent one. It is impossible to predict. So I still get frustrated when people spend half of the interview day putting students through these skills stations to see if they're going to be an okay resident. You may be losing a really gifted resident if you're putting stock in that. The answer is no single test will do it, so don't consider it until we have better data. So we first said, let's develop an operative performance rating system. We spent about 7 years on this process, did comprehensive literature reviews to decide for a hernia repair what technical issues determine poor or good outcome. Those then would go into our rating system. They were case specific, big debate across the country. Just use a generic form for everything. We really felt it needed to be specific. I've since changed my mind. But in each case, we had a 10-item form. We tried it with our faculty. We tried to get compliance. Faculty just said it's too much work, too much to fill out a 10-item form. So we continued to work. This was all validated through an American Board of Surgery validation project where we brought expert surgeons to Philadelphia, asked them to review videotapes as part of the process, and we learned some great things there about faculty rating operative performance. For example, you have to have a resident that's really doing the case before you rate the performance. So it's tough to rate an intern when you're doing 3/4 of the case. So only rate those where they're doing it. Guidance interferes with evaluation. Not sure I would have ever realized what a profound issue this was until we did this study. Attendings underestimate the amount of guidance they provide. If I ask any of you attendings today in the audience, so do you think you are, as they say in parenting lingo, a helicopter attending? So the residents would say, you give almost no autonomy? Or do you really step back and let the residents have autonomy? I'm sure, as surgeons, you would all say, no, I really give the residents autonomy. But if you ask the residents, you'd get quite a different answer. Just to prove this, I said in one of my research team meetings, well, if you want to understand this, I really give great autonomy to the residents, and so that should be the guide. I should never have said that. My PhD educator said, so do you mind if we videotape you and bring you back to this conference to see just how much autonomy you give? And I said, sure, I'd be happy to do that. So they videotaped me, brought me back to the conference. I was teaching a chief resident a hernia repair. I had a third-year medical student next to me. And throughout the entire case, I was talking to the medical student. So what the chief resident's going to do next is going to isolate the sac. Now, after they do that, they're going to be ready to place the mesh. And I was thoroughly humiliated and embarrassed. I was providing absolute guidance. All the chief resident had to do is listen to my conversation with the medical student. They could have been totally unprepared and have done the case well. So we do it in subtle ways. The way we put the forceps. If you're a laparoscopic surgeon, the way you aim the camera or pull the camera away at different fields, we guide profoundly. We have to be aware of that as faculty. Here's the ideal situation. Frank Stritter talked about this years ago. It's appropriate for an intern that you provide a lot of guidance and supervision. But at the chief resident level, it's time to back off. And that's the skill that's required. So our lessons are cueing and fading. Modulate based on the learner. When I talk to faculty about attendings, they'll often say, that attending is great for chief residents. They're terrible for interns. Or vice versa. They're great for interns, but I wouldn't want to operate with them as a chief. And what it means, they only have one speed. It's either lots of autonomy or hovering, but they're not able to modulate as you move along.
be a first assistant for chief residents, develop awareness, and don't do something, just stand there occasionally. We learned a lot about components of operative performance. Again, we're trying to get more specific instead of saying, this resident's terrible in the operating room, or they really have poor hands. We'd like to be a little more specific. And so in review of over 1,000 comments from these experts at the board, we now are able to say, you have problems in one of these 5 areas. Now it's much easier to prescribe remediation that is specific for a resident just struggling, for example, with forward planning. Well, again, in our efforts to make all that we do as easy for faculty as possible, we thought maybe we should do an iPhone app. And so we've created this platform at Indiana University called Personal Best. And we have it all on an iPhone. It was on either edition, and so a resident, after an operative performance, a faculty could just basically click all 10 items, and immediately it would be available for the resident's feedback. But then along about that time, all the research about autonomy started to surface. And we started thinking about maybe this is the problem in surgical training with all of the insurance requirements and all of the billing issues that we have become more and more in a supervisory role. When I look back into my residency training, probably as a chief resident, 70 to 80% of the time, I was really doing the case with the faculty just as a first assist or maybe even as supervisor only. But we really have issues around autonomy. When I asked chief residents as visiting professor, what's the one thing you would change if you could do your residency over? The answer is, in my senior years, I wish I had had more autonomy. And so we then decided, how do we look at this? How do we promote autonomy? So we did a whole series of focus groups that's now been published in Surgery. And one of the things is sequence increasingly complex steps of the procedure for graduated autonomy. We finally have our HBB surgeons to say, let's let the second-year resident come in and do the gallbladder at the beginning of the case. Then they'll leave, and then the chief resident can do the rest. And develop with residents an understanding, when you walk in on your first bariatric case, you're not likely to do the case in entirety on day 1. But if you're with that attending over a period of time, it will be graduated. So I sat down one day and asked our chief of transplant, tell me how you do it with liver transplants and your fellows. And he said, oh, it's very clear. First 15 cases, you're just going to assist. The next 20, just open and Highland dissection. And graduated until only after you can see 75 cases is the fellow now doing the transplant from beginning to end, which is generally near the end of their second year. We've really sort of abandoned that in general surgery with the idea that when a resident enters our OR, they assume they're going to do the case from beginning to end. That's not how I do cases. I'm very clear. For particularly a junior resident, you'll watch on this axillary dissection. The next one you'll do increasing amounts of it. And maybe by the 4th or 5th one, you'll do it all from beginning to end. This is really, I think, a more logical approach to teaching. Minimize queuing for senior residents and use the BID method. If you ever had a doubt about how PhD educators can help you, this is my clearest example. My PhD educator at SIU said, you mind if I just watch you teach in the operating room? And she did this for days. I wasn't sure what was coming from it. And she came back a few days later and came to our research session and said, I could really improve your operative teaching if you would listen to me. And of course, I was anxious to hear what she said for all those hours of observation. And so was born what's called the BID method of teaching. And if you don't take anything else away from this today, and you want to go back to the OR this afternoon and be a great OR teacher, here's a simple, easy way to do it. So at the scrub sink, you say to your resident, how many of these have you done? And what is it about this case that's challenging you the most? Tell me just one thing you want to focus on today in this operative case. Maybe in a lap chole, it's, I don't feel I'm very efficient the way I'm using my left hand as a retractor. I just don't feel very efficient. All right, that's the focus of today's case. Then during the case, you do your usual operative teaching. All of us have teaching scripts that we use for medical students and residents. But when we get to that part of the case, we really focus and give them very specific cues and helpful hints how you might be more efficient. Then at the end of the case, unless the feedback is so serious you need to do it separately and privately, you say, how did you think you did today on handling the left hand? And then you give them specific feedback. When I first started doing that, the chief resident's first response to me was, why do you just wait till I'm a chief resident to start doing this? From the resident's perspective, it was a profound benefit. So every case, they're learning something specific and it's based on what they need, not what I think they need to learn. Try it, see how it works. But by all means, ask the resident if it was helpful. Then insist on resident preparedness, longer senior resident rotations. After this work, we have now doubled the length of our 4th and 5th year rotations and created an almost apprentice-style rotation. Because all the faculty said, the reason I don't give autonomy is I have one 4th year this day and a different one the next day, and I don't know what their skills are. Big problem in a resident program as large as ours. Give me the same resident doing a Whipple every day, I'll gradually let them do the whole case. We'll see if they were serious about that. We'll know in the next year or so. And include autonomy in the operative assessment. And so this is what caused us, several months ago now, about 18 months ago, to have a pilot meeting with the Northwestern research group. They had been researching the concept of autonomy and basically had skipped their operative performance assessment except for this. They believed this was a surrogate for basically quality of performance. So at the end of the case, using the Zwisch autonomy scale, named after Dr. Zwischenberger, the chair of surgery at Kentucky, they basically said, this is the amount of autonomy I gave the residents today. They just watched. It was show and tell. Active assist, they did the case, but I really heavily assisted. Passive assist, I acted as first assistant. Supervision only, I had my hands crossed talking to the scrub nurse or the medical student. And so they felt that that would be an indicator of the quality of performance. So in our combined meeting, I said, actually what would be perfect is to use all of your research around autonomy and all of our research around quality of performance and put them together into one scale that's really simple. The name stuck, and so was launched SIMPLE, SIMPL, a system for improving and measuring procedural learning. So it combines personal best with the Zwisch rating. I don't know how we're going to ever get it any simpler for faculty. It's 3 clicks: case difficulty, overall quality, and autonomy. And then you push a button and give verbal feedback. And we focus it on, here's what you really did well today. Here's what I think you could really improve on if you worked on this. Now, I wish that was always verbal at the end of every case, but every attending in the room knows that just doesn't happen. You're on to the next room while they're finishing the case. But I do have at least a minute and a half, which is about how long this takes, to do 3 quick clicks and verbal feedback on the run between ORs if necessary. Now, the way this works is the resident first completes their own evaluation, same 3 items. That triggers an email to the faculty, and online they evaluate the performance. This is what it looks like on our iPhone app. This is now launched a not-for-profit corporation, PLSC, which is a big research arm of this. The software has now been developed for the iPhone and the Android, and now the American Board of Surgery is sponsoring this study, which is now well underway in 14 residency programs across the United States. All faculty must undergo rater training before they start to use this system, and our research team goes out and does the faculty training. We now have the first results. This was presented 2 weeks ago in Boston at Education Week. 15 residency programs, almost 800 attendings, and almost 500 residents. 6,000 performance ratings, and a response rate of 70%. We could never have imagined that kind of response rate early on. Here's some preliminary data, and I think it's concerning. This is the percent of ratings for quality. Notice the quality of performance. We spent about 3 months deciding what these categories ought to be. So you're either deficiencies, you were not prepared to do this case. You were prepared, but you're still a novice. Intermediate performance, but this is the key. A resident is practice ready. So attending is saying, I think based on what I saw today in this case, they would be safe to perform this independently in practice. And then for those performance that are just absolutely exceptional, you want to recruit these to your faculty. That's 5. So those are the 5 ratings. This is autonomy. And here's what I'm concerned about here. So this is show and tell, which means resident just watches. This is I just supervised. I think all of us would say for chief residents, we would assume maybe half or 3/4 of the cases we would be supervision only. This early data, only 20% of the time for PGY 5 residents did they have the highest level of autonomy. So this is very disturbing. Even when we are reminding faculty, how much autonomy did you give? Now I have to say, when I click a case and I said, this is active help for a senior resident, it causes me to wonder, why didn't I give them a little more autonomy? Were they unprepared? or was I in a hurry and I had another case to do in an hour? And it really, I think, forces faculty to start thinking carefully, and we hope ultimately change the balance over the next few years. Well, this is what drove us from the beginning. So as our research team sat down many years ago, we started to say, so for our residents' cognitive ability, you know that you're at the 85th percentile on ABSITE. You know precisely where you stand. Residents have no idea where they stand with regard to operative skills. Wouldn't it be great to know as a first half of a third-year resident, I'm at the 80th percentile in my operative skills. This is what we're headed to. As we collect data from these 14 programs and then release it for programs all across the United States, we'll, for the first time in the history of American surgery, be able to say to a resident at each 6-month interval, here's where your performance lies, and here is the average performance for all other residents at your level. I can only imagine that a second-year resident finding out they're at the 10th percentile in surgical skills, they're going to call up our skills lab coordinator and say, I'd like to block some time in the skills lab. I need to work on some things. And so we're very excited that I think we're probably less than a year away of giving our first resident report, and these will be every 6 months. Well, over these last number of years, we've learned a lot about if you're going to develop a system of rating performance in the OR, what are some key issues you should consider based on firm literature? And so in the last several months, we've done a comprehensive literature review for both phases, individual ratings and your system ratings of operative performance. We use very established criteria to assess the strength of recommendation, the quality of the evidence, if you will. Actually, we use the East trauma guidelines, which is really very, very well done. Then we had it reviewed by stakeholders, United States, Europe, Great Britain, all over the world, and the American College of Surgeons, and the American Board of Surgery. And it was just accepted for publication in the Annals of Surgery. It's actually available now as a PDL. It's not yet published in print, but will be in the next few months. And I'll just give you some of these items that we've learned. It has to be for single performances directly observed. If it's not done within 72 hours, it's worthless. So our system locks you out. Because longer than that, it's just a halo effect like an end-of-rotation evaluation. So it needs to be done quickly. And this is based on very strong data. It ought to include a report of autonomy, case complexity. You have to train faculty, especially around Zwisch ratings. So we show them videos in the operating room and say, what autonomy do you think this is? So that we're all rating on the same scale. And then the dialogue is most effective, even though it doesn't always happen. That's still the most effective at the end of a case. These are the practice guidelines for your system of rating operative performance. It's a way to make sure it's a good, valid system. We've decided you just should try to rate all ratings. If it's random, that's okay, but it should not be the resident choosing the rating. They may choose a case they've done many times before, and they know their rating is going to be excellent in this area. So if you feel you can't do every rating, make it random. But with our new system, it is so easy to do every case. Again, 2 minutes or less for a rating. You have to have at least 10 raters to balance rater idiosyncrasies. If you do this, it balances out the hawks and doves. Now, I'm sure you don't have that at West Virginia, but in most programs, we have those who've never seen a resident they didn't like, and they've never seen a resident that performed adequately. And so you really want to balance out those two ends of the spectrum. 10 raters does that. The operative performance is stable enough to do it every 6 months. Don't make decisions based on one report. The Milestones Committee now uses all of the ratings that you have accumulated and makes decisions as a milestone group based on those ratings. And again, to assure that your chief residents are competent and ready to graduate, you need multiple ratings with high autonomy. The American Board is now looking at this because they're really concerned about autonomy. And I talked to Steve Stain, one of the leaders, just a couple of weeks ago and said, we have given you the perfect platform to decide if a program is giving chief residents enough autonomy. So I've encouraged the board to consider this system as they try to assure more and more autonomy. Well, let me just mention briefly what we do in the clinic. As you know, this also is now required. You have to provide residents an evaluation of how they've done in assessing and working up a patient in the clinic before they take their American Board of Surgery examinations. So here's all the ways you could do it. You've got a great menu. All of these areas, some are much more costly than others. I think probably the single best one on the list is the PAME, the Patient Assessment and Management Exam. We use CAMEO, which again our research team developed. This is the PAME. But again, it's so faculty intense, takes a half day. Faculty watch residents performing with standardized patients through a one-way mirror. Residents then go out and order all of the tests, come back in and decide what needs to be done in the patient. And I can tell you there's more valuable information gleaned from a pain than any other thing I've done in a short period of time. Again, it's just very expensive and faculty intense. So we did this for many years at Southern Illinois, and Northwestern was doing it simultaneously. So there's quite a case volume built up if you decide you want to do that here. But again, our research team was focused on what could we do to make it as easy and simple as possible for faculty. That's the CAMEO, Clinical Assessment and Management Exam, Outpatient. So we rate patient evaluation in the clinic. We rate all of these skills as we watch residents interact with patients. It also gathers our patient satisfaction data. It's the easiest, simplest way for us to do it at the end of a case. It's all managed by a new hub. And just the other day, our residency coordinator came up and said, I have an idea that will make this even simpler. I'm going to put this on the back of all of their name badges. So in the clinic, when it's time to do a CAMEO, all you have to do is scan. All of us have scanners on our iPhones. That's how we check into Grand Rounds. You just scan their name badge, and a CAMEO pops up, and you just click off the ratings. How could we make it any easier for faculty in the clinic to do on-site ratings? No more paper form and then transfer to MedHub. And so we think this has, again, made this easier. We'd like to get more than 2 when you finish. Our goal is that if you're working with a resident in a clinic for a month rotation, at least once or twice that month, watch them. Now, this means for a new breast cancer, I have to go in with them. I have to watch them do an axillary exam, for example. Then I have to go in with them or in the consult room and watch them explain the diagnosis and treatment options to a patient. I can tell you I've learned more in that experience than I would have ever imagined, because often we just don't let residents do that, or if we do, we don't observe it. To watch their patient education skills and how they deal with these difficult ethical issues is a profoundly valuable experience. And so the CAMEO, I think, is the easiest and simplest way to do that. And if the residency coordinator is here and wants to find out from Breanne, our coordinator, how to make this even easier on your name badge, it's a pretty easy thing to do. Well, in summary, let me express appreciation. This kind of research would not be done without a great team, and in Indiana, we're sort of accumulating that team. Laura Torbeck is our PhD, is now the Director of Professional Development. She does all of our peer coaching of students, residents, faculty, how to improve their teaching skill. Reed Williams is my PhD researcher and an expert on performance evaluation that's worked with me now for 17 years. And we've just recruited, beginning in August, Dimitri Stefanidis, who is probably the premier researcher in the U.S. on simulation in surgery. And then along with him, we're taking a new twist, a sports psychologist. We believe we should approach training in surgical skills much like the Colts approach training at their skills facility. So this sports psychologist is absolutely convinced of that and will bring a new level of skills coaching in our skills laboratory. The other thing that is vitally important, several years ago, a mentor of mine said, it's always going to be difficult to get NIH grants for educational research. I don't believe it's impossible. I'd still like to achieve that. In fact, Dr. Stefanidis, who I just mentioned, has a $750,000 ARHQ grant. But we worked hard with Biotech, which is a subsidiary of Cook Catheter Company at IU, and they've now given us a $2 million grant to fund surgical education, research, and innovation. So this really allows us some flexibility in the kinds of things we investigate and the new innovations that we're working on. So in summary, if you're going to really measure and improve performance, you have to separate the practice arena from the performance arena. You cannot send interns to the performance arena on day one. You have to broadly sample trainee performance. Just look at your ratings in your residency program. How many ratings do you have per year? I asked Dr. Williams one morning in our conferences, how many do you need? And about a week or two later, he came back and said, have no idea. It's not in the literature. So I said, well, you should find out. And so over the next 3 or 4 years, we did the research, and so we can tell you the answer. You need 38 ratings per year. Now, if you weren't looking at professional behavior, you would require a lot less. That requires a lot more ratings. But this would be your end of rotation, your CAMEOs, your operative performances, everything you do. You need 38 per year for resident. Measure performance based on direct observation. In our program, if it wasn't observed, it is not rated. Look at your resident end of rotation evaluation. See how many of those things you're rating, but you really didn't observe. It's hearsay. I heard the nurse say that another nurse said that that resident in the middle of the night did a great job working with a family. well, I rate them as outstanding in that area. That's not direct observation. So only rate those things you observe. Promote greater autonomy. We're doing everything we can to make this a highlight across the country. And measure, don't assume for proficiency. Don't assume just because they attended every skills laboratory session, they got it. They're ready to move on. Test them and make sure they're competent before they move on. David Leach said years ago, whatever we measure, our goal is to improve, and that's really the underlying philosophy of what we're trying to achieve. Thanks again for the privilege of being here, and I'd be happy to entertain any questions you may have. Yes. Faculty. Yeah, we don't yet have that comparison, but the early data from Northwestern is very clear. Residents think they had a lot less autonomy than faculty believe they gave. I mean, that's not a real surprise. So we'd like to see those move together over a period of time. And I think it'll be very instructive for an individual faculty. If that gap is really wide, they probably need to sit down and have some discussions with their chief residents. What is it that I'm doing that's preventing you from feeling I have autonomy? Yes. If you look at personal best, on the opening of that website is Atul Gawande's coaching article, because that really affected us profoundly. So we are really just now starting to move to that area of providing feedback for physicians in practice. As you can imagine, that is incredibly sensitive. So if I ask, who in this audience of surgeons wants to volunteer to have a coach and let them tell you how good a surgeon you are? So the way we think we're going to approach this is look at Indiana University alumni graduates still in the state and approach them and say, if you're doing general surgery, would you like to have one of our HBB surgeons view a series of maybe liver resections you've done and provide you some coaching? So start on a small scale. It's that barrier that's prevented us from doing it. We now have the platform in Personal Best. You can go on Personal Best and say, I want to sign up for a coach, or I want to be a coach. So we have the platform. Now we need to just get brave enough to do it. The concept makes so much sense. You can be in the NFL for 15 years, and you're still being coached every practice session. And yet we think in year one of being a faculty member, okay, I'm finished. And that's just, it just does not make good sense. So you're exactly right. That has to be the direction of research. Yes? Yeah, that's a strong word, schizophrenia. We're trying to treat the schizophrenia with a lot of the research we're doing. There is a real challenge. And I can tell you it's the tension at the board between, to say this very carefully since I'm one of those senior folks now, among a group of senior surgeons who are clutching onto the way we've always done it and do not want to change, and a group of us who've been saying, for example, now for 15 years, are we ever going to figure out that the best way to train residents is 3 years of a core and then go on to specialty? As I said at dinner last night, a task force almost achieved that about 6 years ago. And a group of senior surgeons in pediatric surgery, I don't know if we have any of those here, and transplant surgery said, no. We can't take a resident until they become a chief. We wouldn't think of having them do one of our cases until they finish 5 years. And that's schizophrenic. And so that's the tension we're developing. So when they say more cases, what I think they mean, as I've heard their translation is, we want chief residents to do more teaching assistant cases, which we think will drive greater autonomy. And that's what I'm talking to the board about, is to say it's not just more cases. That's teaching by immersion, thinking if you do enough, you'll finally figure it out. What we need is more autonomy and more skills training. So you've read it well. There is a tension that results in looking a little schizophrenic at times. I wish it were different. Surgeons are pretty strong-headed and reluctant to change. Yes? So that's why we put it up right up front. So by the end of boot camp, they may have only done 10 or 12 cases in the OR, maybe a lump and bump. I'm not saying they can't do a sebaceous cyst in the OR, but they're definitely not going to do a laparoscopic cholecystectomy in the first 3 months. But once they finish boot camp, which is now early October, then they're ready to go to the operating room. And so far, our residents have exceeded that 250 by the end of year 2. And a lot of it, I think, is because faculty know they're ready to do the cases. And they know if I'm certified to do a lap chole, somebody has watched me do it very carefully and has said they're ready for the operating room. So we have not had those problems with numbers. Now, our clinical volume is pretty spectacular. I don't think spending 12 weeks in a boot camp is going to prevent us from doing that. It'll just result in better training overall. Yes? Good. We have not yet addressed that. I don't think we'll have much success, for example, insurance companies at this point. But I think you can do autonomy and still be present for critical portions of the case as is required. You may be sitting over in the corner. So what this has resulted is a significant increase in our program, particularly on the emergency general surgery service or acute care surgery service. And as I go around the country, that's where the autonomy is really growing. And we have our acute care surgeons willing, even during the daytime, to sit over in the corner and let the chiefs take the third years. That wasn't happening before. So we've really focused our autonomy on that particular really serious cases. So I think there are pockets where you can do this, longer rotations. I'd rather do that than tackle insurance companies at the present time. I don't think that's going to be successful. Right. Yeah. Yeah, don't get me started on the milestone. If you want to see my views on it, what I thought was a really good critique of milestones. I was surprised it was published because it was fairly critical. And I think what orthopedic makes a lot, there are even bigger problems. It's what we work with. It's a good first step. I hope we're getting close to a revision soon. Yes, last question. Let them go as attendings. Thanks very much.